My name is Ian McDougall. I'm from King's College Hospital in London, and it's a great pleasure to invite you to the second half of this discussion on anemia therapies, specifically in the nephrology indication. We're going to hear three very short presentations from Antonio Santoro, Gert Meyer and myself, and then we'll open it for a general panel discussion. So really, without further ado, I'd like to invite Antonio Santoro from Bologna to talk to us about ESA management in anemia of chronic kidney disease. Thanks, Antonio.
Thank you, Jan. Yes, I'd like to show you the conclusion of our group of nephrologists present in this meeting. And these are not a guideline, but only the recommendation and the personal opinion of all of us. The first recommendation is in presence of anemia related to the absolute or relative hypodeficit, we have to exclude other causes of the anemia, and this is obvious. The initiation of specific therapy may be at the hemoglobin level of less than 11 grams per deciliter. But it is very important the tailoring of the target in individual patients. This is in spite of the guideline, because we have also to look at the quality of life of the patients in this. The optimization of the ESA therapy may be done in different patients, but we have to check before the optimization of the ESA therapy the iron deficiency, and then we can start with iron supplementation when we have the iron deficiency. And lastly, in patients with reduction in responsivity and to ESA therapy, we have investigate about different other causes, different causes that deficiency in iron or inflammation of the patients or poor quality of dialysis of increase in PTH. But we have also many open questions and question marks, because the first is that the target of the hemoglobin levels may be different in different setting of patients with different comorbidity, like patients with heart failure or patients with thalassemia or other kind of comorbidity. And the other open question is when do we have to start with the treatment, very early or late? And the other is that probably we need, at least in routine dialysis, interactive electronic algorithm models for the delivery of the IV iron and the ESA dose. And the other is the problems of the benefit and harms of high versus a low fixed ESA dose. And this is the problem. Is the high dose or is the high target that may influence the outcome of the patients? And last opinion for us is that we need probably different kind of monitor approach in different patients, because we can have a different frequency and different kind of monitor in different patients. These are our conclusions.
Thank you very much. We'll move on to our second presentation, which is on the specific use of iron therapy in anemia of kidney disease. It's Gert Meyer from Innsbruck. Thanks, Gert.
Thank you very much. I think that we all know that we achieve much better quality of life in our patients on dialysis and also in the pre-dialysis population if we aim for higher hemoglobin levels, especially in the target range. I think, and this is something very important that we have to consider, but I think it's also clear to the nephrology community that especially if you are aiming for higher hematocrit levels, as has been done in the normal hematocrit trial, as you can see in this slide, that we can run into some problems, especially if you do not achieve the hematocrit level that you wanted to achieve. And this is to the left, where you can see that if you aim for 42% hematocrit, but you only reach about 30, the prognosis is very poor. as far as mortality is concerned. I also would like to point, however, to the far right of this slide, where you can see if you really achieve the target level of 42 that you're aiming for, the prognosis is very good. So we are left with this problem with quality of life and probably having to use very high ESA doses in those who are resistant. And in order to avoid the high ESA doses, you might consider to use more aggressive iron therapy. And this has been done in the DRIVE study, a study with ESA-resistant patients, where they were adding to the increase in erythropoietin that every patient got in the DRIVE study, one group of patients who got IV iron quite aggressively. And you can see, indeed, the hemoglobin level is increasing significantly more in the IV iron group, and more patients reach an increase in hemoglobin of more than 2 grams per deciliter. The question is, does the iron work orally or intravenously? And this has been tested in the pre-dialysis population, where you can see that if you aggressively administer IV iron, you have a higher treatment response over the treatment course of 56 days when compared to treatment, oral iron treatment. I think this is also true for the dialysis population. Nonetheless, we have to consider that there may be side effects of oral or high-dose intravenous iron therapy especially. And this is a slide from a study showing that intravenous iron therapy is actually increasing FGF23 levels. We know that oral IV iron therapy, especially if it's high-dosed, induces hypophosphatemia, and this is the explanation for that. We also know now from epidemiologic studies that high FGF23 levels are at least associated with poor prognosis. So I think there is still some matter of concern. And the other problem that we are facing in nephrology, we don't have good biomarkers to guide iron therapy. This is again from the DRIVE study, where you can see that in the question of who is responding to the additional iron therapy, the sensitivity and the specificity of transferrin saturation and ferritin is around 50%, so you can flip a coin. Basically, to summarize, I think there is a trend for more aggressive iron therapy in the renal arena. The safety of this approach needs to be determined. The trend may be driven by the idea that we should avoid high ESA therapy, high-dose ESA therapy, but nonetheless achieve the higher target levels. And finally, as I pointed out, the biomarkers that we have available right now, I think in some critical clinical settings are quite poor. Thank you.
Thanks, Gerd. I'm just going to finish off before we have the final panel discussion with a brief update on where we are with anemia guidelines in nephrology. That's my disclosures. In the last 12 months, there has been a lot of discussion after the large randomized controlled trial, the TREAT study, and there are 2 sets of guidelines. One is already published and one is about to be published in the next few months. The UK NICE anemia group have published in February this year their update on how to manage anemia with largely in relation to ESA therapy in kidney disease. And then the second point I would like to address is the update on the KDIGO, the clinical practice guidelines for anemia and chronic kidney disease. So I have one slide on each of these. So these are the main conclusions from the February update of the UK NICE anemia group. And you'll see there's a certain similarity between the NICE anemia guideline and the KDIGO. There is some overlap, but there are some differences as well. The first point I think that is both sets of guidelines address is first to correct any other cause of anemia. So if there's anything correctable that can be corrected first before using ESA, or particularly iron therapy perhaps, then that should be addressed first. And then the question then is if there's a possibility that there may be an improvement in hemoglobin with iron therapy alone, and there's the question of whether this would be intravenous, which is probably more effective than with oral, which could be used perhaps in non-dialysis patients. Certainly in dialysis patients, I think it's mandatory to use intravenous iron because of the effects of hepcidin limiting iron absorption from the gut in that population. And then there are discussions about the trigger hemoglobin for starting therapy. And in the NICE anemia guideline, they're suggesting around 11 gram per deciliter is a reasonable trigger, below which perhaps quality of life starts to diminish. And the aspirational range, as they talk about, rather than the target range, they have this aspirational range of 10 to 12 gram per deciliter, which I think is what a lot of nephrologists are doing already across Europe, and we'll be discussing this with the panel in just a minute. So moving on to my last slide, which is the KDIGO guidelines on anemia, and I want to emphasize that this is the public review version. This is not the final version, but so that is the disclosure that I'm putting across this. So this has gone out to public review. That's been completed. The comments have been collated and are currently being considered in perhaps a revised guideline, and the final version will be due for publication mid-2012. But this is the guideline as it went on the KDIGO website over the last few weeks. So again, there's an emphasis on correcting other causes of anemia first, and considering intravenous iron with perhaps oral iron in the non-dialysis kidney setting. And there are some markers of iron sufficiency that have been introduced into this guideline. I emphasize again, this is not necessarily the final guideline, but the suggestion at the public review stage is up to a ferritin of 500 and a transferrin saturation of less than or equal to 30%. There might be a case for attempting intravenous iron therapy first. And then the trigger hemoglobin, there's an absolute feeling that below 9 there would be a strong indication for starting ESA therapy, partly for quality of life and partly for reducing the need for future blood transfusions. And you should consider this about 10 gram per deciliter, really intervening early to prevent the hemoglobin going below 9. And then finally, the upper hemoglobin ceiling, there's a suggestion this could be around 11.5 gram per deciliter, which you can see is slightly more conservative than for the NICE anemia guideline, and certainly there's a strong suggestion to not intentionally exceed a hemoglobin of 13 gram per deciliter, and that's based on very strong scientific evidence. And then the final comment that both sets of guidelines make is individualization of therapy for the patient that's in front of you at the clinic, rather than just expecting one size to fit all. So that's all I want to say. I would like to just now introduce some general discussion from the panel about these issues in relation to anemia management. So we have representation from quite a number of European countries, from Spain, from Germany, from Italy, and from Greece. And maybe we should just go along in order. So I'll start with you, Juan, at the end in Madrid. What do you feel about these kind of anemia guidelines? Are they consistent with what you're doing in your practice?
For me, the key point in the treatment of patients on chronic kidney disease is the individualization. It's not the same an old patient with diabetes mellitus, with a high comorbidity, and even in a wheelchair, than a young patient with glomerulonephritis, working with an active life. It's not the same, and in this regard, treatment shouldn't be the same. What we are doing is initiate treatment with IV iron in patients with advanced chronic kidney disease, and of course in patients on dialysis, either on hemo or on peritoneal dialysis, with a range between 10 and 11 grams per deciliter. And we try to maintain the levels between 10 and 12, depending on the characteristics of the patients. For me, hemoglobin levels is not the problem, because we need to have in mind that physiological levels are 12, 13, 14, or even more. In my case, the last hemoglobin level is 14.5, and I think it's not a problem. The problem is what we need to achieve these levels. Okay. And what is clear is that we don't need to use very high doses of ESAs in patients with hyporesponsiveness.
Okay, thanks, Juan. Can we move to the ostium view? Gert, you talked about iron management and you gave us some data. Can I just ask about your personal view of iron and particularly maybe in the non-dialysis setting? Do you try oral iron? Do you use intravenous iron exclusively?
Well, currently we are still giving the patient a chance on oral iron. We are participating in the studies of high-dose IV iron, and I still think that we should wait for not the efficacy, because I think the efficacy will be clear that it's better, but to get a little bit more insight into safety on the long term.
Sure, that's very good. So we move to Greece. John, do you want to comment on any aspect of the anemia management in your unit in Greece?
Yes, regarding iron therapy, most of the nephrologists in Greece use IV instead of oral, given the low compliance of the patients and the problems with absorption, mainly on hemodialysis patients. So for hemodialysis patients, it's a rule, the IV infusion, and for the chronic kidney disease patients, it depends. Regarding the target level of hemoglobin, it's always no more than 12 grams per deciliter, and it's more or less around about 11.
Okay, thanks very much. And Antonio, what do you feel in Bologna? What is the score?
Yes, well, it's quite similar. This we start the hypotherapy, or we start with the iron when the patients have 10 or 11 grams per deciliter of hemoglobin, and we have the upper limit of 12.5. But now we have in Italy a large trial. The chairman is Giovanni Stripoli. About the name of this trial is C-dose, and is the comparison between high dose of EPO and low dose of EPO, and the end point of the study is the outcome of the patient. This is in order to define if it's important in the outcome of the patients or in the side effect, the high quantity that you give to the patients of ESAs, or is the target of the hemoglobin that may be induced several different side effects like thrombosis of the vascular access or stroke. I think it's very important to define that if we have to reduce the dose of the ESAs in the patient, in the dialysis patient, not use very high doses, like in oncology.
Danilo, what is your view in Germany?
Well, I think with the upcoming KDIGO guidelines, there will be no major changes with respect to the nowadays practice, because in Germany we aimed also in the past at the hemoglobin level of about 12 grams per deciliter. So there will be no change with respect to the target hemoglobin levels. Even with the iron treatment, there will be no major changes, because we started with iron mostly intravenously also in the pre-dialysis patients. There might be some disagreement with respect to the start of the EPO treatment, because personally I believe that the target, or to wait until a patient drops below 10 or even below 9 is too low. And the everyday practice in Germany is different. We start when patients start to feel bad, and when they drop below 11, below maybe 10.5 grams per deciliter. And to my personal opinion, it makes no sense to have a target of 10 to 12 grams per deciliter, but wait until the patient drops below 9. So I think there will be a disagreement with the KDIGO guidelines, but otherwise all other points will be similar as nowadays.
Back to you in a minute. I'll maybe just finish the nephrology discussion first of all. So, yeah. I mean, I agree with a lot of that. I'm part of the KDIGO group. I would say that in the UK, that some of the guidelines, if they go ahead as drafted, will be considered more aggressive than a lot of nephrologists will go for. So I tend to agree. I don't think that in the UK, nephrologists are going to let people get near 9 grams per deciliter. I think the 10 to 12 range will persist regardless of KDIGO. I think that might well be the case in Europe, and I can see a slight disconnect. I think perhaps the US might follow and get more conservative with anemia management, maybe not, but I think in Europe there's a good chance that the 10 to 12, as per the current product labels for the ESAs, will remain for now. Maria, I mean, you're not in nephrology, but listening to all the nephrology discussions as an oncologist, what do you feel about all of this?
The major difference I see in the attitude is that the usage of ESAs and iron in the oncology setting is essentially in advanced, non-curable disease.
Yeah.
So we are dealing much more in the short term, while you are following patients for many years. So it's a completely different situation. Yeah. And for me, it's very interesting to follow what is being said in your field.
Can I ask you, Mario, to comment specifically on the malignancy, the cancer-related deaths data from the TREAT study? Because this is something that has been extensively debated amongst nephrologists, and I think oncologists might have perhaps a different view. What do you feel the feeling of oncologists is regarding that tenfold increase in cancer-related deaths?
Well, the same thing as what I just said. That's in fact not really our issue, but I must say that when I read that paper in December of 2009, and I made slides for my next talk, I included obviously the paper because at the end the editor of the paper, the writer of the paper, he says this might be important for oncologists. Of course it's important, but we are dealing in a completely different time frame. So it's different. That's why we have problems with MDS, where again, most of the people who do not transform rapidly into acute leukemia, they have years in front of them. So the situation is different.
Sure. Okay, it's very interesting. We have, this is a live webcast, and so there's the ability for you out there to send in questions. And we actually do have 2 questions that have been sent in from you out there. They're both from Saudi Arabia, so that either means that they're the only country that are looking at it, or the only one that are brave enough to send in a question. So I'll read out the 2 questions, and then I maybe direct them generally to the panel for discussion. So one of the first question came really to want some guidance on how to manage resistant anemia in CKD patients. How do you manage that? So we'll come back to that question. I'll maybe ask Gerd to think about that because he discussed a bit about resistance anyway. The second question is a debate about the relation of higher doses of ESAs and reported side effects. Is it a true side effect of ESAs, or is it due to the higher achieved hemoglobin levels? So I think they're both very interesting questions. We can maybe open them for discussion. So Gerd, did you want to just address the issue of ESA resistance? You talked about the role of iron. Maybe you could discuss that and how to manage ESA resistance.
Well, I think it's pretty clear that you should try to make a good differential diagnosis. But we all know that we end up with patients where we don't find the inflammatory focus, we don't find vitamin deficiency, hyperparathyroidism is not a problem, or it's a managed problem, and still the patient is a resistant. And I can only tell you my approach to that issue, and that is I'm very conservative with these patients. We do have in our unit a limit on the ESA dose, maximum limit. We do not push for high hemoglobin levels with aggressive iron therapy in these patients, but we mostly are happy with the hemoglobin level that we can achieve with a limited effort, because I'm not sure that you should push in these very resistant patients massively for higher hemoglobin levels. Usually they don't also profit as far as quality of life is concerned, because they have a somewhat reduced activity level, because we all know these patients. So we take a very conservative approach, and sometimes I have to tell you, we even stop ESA treatment in these patients.
Okay. And then Juan, if I come back to you, and so the issue of whether the high hemoglobin itself is bad for the CKD patient, or is it the means of getting there with lots of ESA? What is your view? Do you think the high hemoglobin is bad or not? Sorry, Juan. Yeah.
Well, Juan, I think high, normal hemoglobin levels is not bad. Probably the efficacy of hemodialysis is going down with hemoglobin levels higher than 12 or 12.5. But in general terms, it's not bad. And in our unit, we have 15% of patients without ESA treatment and with normal levels of hemoglobin, more than 12. And I think it's not bad. It's not a problem for the patient. The problem is when you need to treat low levels with high doses, and the necessity that the physicians have to look for what's happening in these patients. In some cases, there is an occult source of inflammation, as an old AB graft, a kidney graft, non-functioning kidney graft in a patient on dialysis, a periodontal disease, or even other factors that are inducing this resistance. And we need to look for these source, these factors that are disturbing the situation.
Okay. Now we've just had a third question in, and believe it or not, it's also from Saudi Arabia. So we have the one viewer from Saudi Arabia asking lots of questions here. So the third question from Saudi Arabia is, does hemoglobin fluctuation have a negative impact on patients, or is it only the higher hemoglobin levels? So I was co-author on a paper published in JASN fairly recently on hemoglobin fluctuation, where we really found that there was no impact of hemoglobin variability on outcomes in a large European database. I don't know if anyone has any views against that. I personally think that it's not been absolutely proven. It's very difficult to do a randomized controlled trial, in fact almost impossible, of hemoglobin variability, so it tends to be observational data. But the question really is whether a fluctuating hemoglobin has an impact on hard outcomes in patients. Does anyone feel that it does? So we have some unanimity here. So nobody wants to disagree with me.
For me, the variability of hemoglobin levels per se is not a problem. In some cases, it depends on the patient, the comorbidity of patients. And the problem is not the variability, is the source of this variability. In other cases, is the result of a very bad practice for the physician. If you see your patient only once a week, once a month, probably you induce a variability. And in this case, maybe a problem. But in general terms, variability per se is not a problem.
Okay, I'm going to ask Daniela the final question, and it's in relation to hemoglobin variability. And Daniela has done a lot of work with longer-acting ESA therapy. So I wondered if you, Daniela, if you wanted to comment on whether you believe the longer-acting ESAs cause less hemoglobin variability than the short, or whether there are other factors.
Well, actually, we indeed saw that longer-acting ESAs cause less variability in hemoglobin levels. I personally do not believe that hemoglobin variability is connected to outcome. It's another problem probably behind that. But indeed, it seems that particularly if there are younger colleagues who are not so experienced, if you have to adjust more times per month the treatment, then you have more variability in hemoglobin levels.
I think we're just about out of time looking at Mario's watch, and I just want to hand back to Mario to close the session. Thank you.
Well, I would like to thank the participants in the meeting, but also on this panel for what has been done. I enjoyed very much this meeting. It's the merger, or not merger, it might be exaggerated, but the come together of two different specialties and looking at the same problem from different angles was certainly very interesting, and I hope that the audience that was watching us now enjoyed that also. I would like to repeat that this meeting is sponsored by Johnson & Johnson, but that everything you have heard and said is to the responsibility of the panel, and also especially regarding off-label use of drugs. So thank you all, and I hope you enjoyed as much as we did here. Thank you all.